Good morning, everybody. It's Dr. Nick Samadani. It's day 2 of the summer semester in 102, in A&P 102. Hopefully you guys are settling in and have ordered your books and started reading the chapter on chapter 12. Hopefully you've been watching the lecture and the upcoming lectures, which are going to be delivered live as long as I have an audience. So today I'm going to cover the rest of chapter 12 and hopefully finish it today. If I don't get to finish it today, I'll finish it tomorrow on Wednesday. So let me share my screen and bring up my PowerPoint here. So essentially, we were talking about the structure and function of neurons as well as neuroglia, right? So we found out that neurons are the ones that are electrically excitable, that can carry electrical signals, and can communicate with other neurons or effectors, such as skeletal muscle or smooth muscle or cardiac muscle or glands, or the intestines, for example, and the enteric nervous system. So we're going to be talking about the electrical signals in the neurons. This is a very important part of the chapter because it deals with material that's going to come up over and over again as we talk about signal transmission and so forth. Okay, so these excitable cells that are neurons are going to communicate with each other via action potentials or graded potentials. Graded potential is the same thing as local potential. So if you see either of those terms on your exam, don't get confused. Graded is the same as local. Action potential is the nerve impulse that travels down the axon. It travels rather quickly, depending on the myelination of the axon. And then graded potentials are lower potentials, right? That can summate or add up to an action potential, sometimes by themselves, most of the time with the help of other graded potentials. So they're like almost like mini action potentials that can summate into an action potential. And we're going to talk about that. So action potentials allow communication over short as well as long distances. For example, I have a problem with my sciatic nerve right now. I have sciatica, and the action potential that causes my pain travels from my hip area all the way down to my foot. And so it can travel long distances along the sciatic nerve, which is the longest nerve in the body. But graded potentials allow communication over short distances, which means that they can add up to an action potential within the soma of the neuron, within the cell body of the neuron. And they travel only short distances within the cell body, right? And in order to produce an action potential or nerve impulse or graded potential, what you need is a resting membrane potential. And the resting membrane potential is there because of the presence of ion channels. And it's the ions, such as calcium, sodium, potassium, that are running these potentials, basically. So start thinking about ions and a little bit about chemistry. So we covered in 101, chapter 2, a little bit about chemistry. And we learned that these ions, such as potassium over here, right? These ions are elements that have lost or gained an electron, for example, or lost or gained 2 electrons, or whatever the case may be. So in the case of potassium, potassium has lost 1 valence electron in the outermost shell and has therefore become positive, right? Kalium is potassium, which is for K. So K plus has a positive charge, and these ion channels, right? These ion channels that are protein molecules within the cell membrane. So this is the cell membrane. If it rings a bell and brings up some memories, this is the phospholipid bilayer, right? And within the phospholipid bilayer are these protein molecules, which are ion channels. So some of them are potassium channels, some of them are sodium channels, some of them are calcium channels or chloride channels, depending on what the need of the cell is, right? So let's look at this slide over here. We know that there's leakage channels that are open all the time, and there are more potassium leakage channels than sodium leakage channels, which means that potassium is going to leave the cell, right? Like here, going to leave the cell more often than sodium is going to enter the cell. So we're going to lose positive charges, right? Because we have more potassium channels than sodium channels. And it's going to cause a negative potential inside the cell, or contribute to the negative potential inside the cell. So a typical neuron, when you place a voltmeter electrode in here inside the cell, and you connect it to a voltmeter and a ground, you're going to measure the voltage inside the cell, inside the neuron. And it's typically around negative 70 millivolts. So remember the negative. That's the most important part. It's negative 70 millivolts, which means that there's more negative charges inside the cell than there is outside of the cell. Okay? Now, ligand-gated channels, they don't like open and close randomly. They open when there is a ligand, which means a chemical, bound to the receptor, which is also an ion channel. This is also a protein molecule, right? These are protein molecules. So for example, this molecule here, this red one, and this red one are acetylcholine. It's written like this, acetylcholine. So we're going to see acetylcholine over and over again. So get used to acetylcholine. Let me get my... So this is acetylcholine right here. It's going to bind to the receptor, which is also an ion channel. It's going to open it up and allow calcium or sodium inside the cell. Right? So chemical stimulus is going to open the channel. And that's what happens at the level of the neuromuscular junction, for example, where the nerve is going to connect to the muscle, right? How does it communicate? Via acetylcholine, the chemical messenger. How does it open up the channel? By binding to this receptor. What happens when the channel opens? Sodium rushes in and depolarizes the cell, which means that it makes it more positive, because sodium ion is positive, right? Na plus. And so is calcium, calcium 2 plus. Okay? So start thinking about these concepts and how they work. And each of these channels has a permeability coefficient, which we won't get into. But if you go to graduate school or beyond, or upper division courses in physiology, then it gets very detailed. They examine all the current flow and how many positive charges flow across, at what rate, and so forth, and how they can manipulate these channels for treatment or for healing purposes, right? Okay. So we looked at the leak channels, which are opening and closing randomly. We looked at the ligand-gated channels that open and close in response to chemical substances attaching to them. And then there's mechanically gated channels that respond to mechanical vibration or pressure, okay? So you press on the skin, for example, right? And these channels open up. These channels open up and they allow calcium or sodium inside the cell, make it more positive inside, therefore depolarize the cell or the neuron. There's also voltage-gated channels. So when the voltage changes, when it goes from -70 to -50, right? Then it opens up these potassium channels that are going to basically allow the cell inside to become less negative, right? Because you have positive charges leaving. So this is a summary of the channels, ion channels in neurons. So we have the leak channels, ligand-gated, mechanically gated, and voltage-gated. Okay. Any questions on these channels? I know it's a brand new concept, and it takes a little while to conceptualize and sort of let it sink in. But do you have any questions right off the bat? Something you don't understand or?
Professor?
Yes.
Can you give an example of the voltage gated channel?
The voltage gated channel? Yeah.
Yes, please.
Yeah, so the voltage gated channel responds to direct changes in membrane potential. So, for example, they're located along the axon of the neurons, right? As the action potential is traveling along, it's causing changes in the voltage. And as the voltage changes, these channels open up, for example, and let potassium outside of the cell. So they respond to not ligands, not mechanical stimulation, they respond to voltage changes. So they open up when there's a change in voltage because of the way the membrane protein is set up. It has some charges on the outside, some charges on the inside. When there's a change in electrical activity around that ion channel, it's going to open up the channel and let potassium out, for example. Okay, good question. Anybody else has questions? Okay, we'll move on to the resting membrane potential, which is a very important concept. So the resting membrane potential is just that. It's the membrane potential of the cell, of the neuron at rest, right? So why is it -70 millivolts inside the cell with respect to the outside of the cell? Because of unequal distribution of ions across the plasma membrane, like we saw, because there is more potassium leak channels than sodium leak channels. So more potassium is leaving the cell than sodium is entering the cell. This results in a negative balance, right? You have more positive charges leaving than positive charges entering. Also, because most anions cannot leave the cell. What are the anions? Anions are negatively charged ions. Some of these anions are rather bulky, right? Like the sulfate anion, SO4 2 minus, or the protein anions, right? They're bulky, they're negatively charged, and they cannot leave the cell. So the phosphates also are bulky, and they're -1 or -2 in charge, and they cannot leave the cell because they're big molecules, big ions. And the other one that's the major contributor is the NAK pump. The NAK pump is going to pump 3 sodium out and only 2 potassium in, right? Because the sodium concentration is higher in the extracellular fluid than in the intracellular fluid. And the opposite is true for the potassium. Potassium is more concentrated inside than outside. So the NAK pump, what it does is that it pumps 3 sodium out and only 2 potassium in. So the result is a -1 charge per cycle, right? So it's going to contribute to the negative charge within the neuron, inside the neuron. Okay, so this is what I was referencing to here. This is how they measure it, basically. So they put a micro electrode inside the neuron, and they attach it to a voltmeter, millivolt meter, and you have a reference electrode in the extracellular fluid, and it reads -70 millivolts inside. Okay, so this is the setup here. In the extracellular fluid, you're going to have positive charges lining up on the outside of the plasma membrane and negative charges on the inside of the plasma membrane in the cytosol. Remember, the cytosol means the fluid in the cytoplasm, right? So that's how they measure it. And then you have the leak channels that we talked about, the potassium leak channels, which are in blue here. And you have the sodium leak channel, which is in red, right? So it's bringing in some sodium ions, right? But these guys are taking out more potassium ions because the leak channels for potassium are more numerous. And then this is the NAK pump, the NAK ATPase pump. It's pumping 3 sodium out and 2 potassium in and using an ATP molecule per cycle. In fact, people who are hyperthyroid and are on the thin side and are intolerant to heat, for example, they have a lot more NAK pumps in their plasma membrane. That's what the thyroxine hormone does, actually. It puts more of these NAK pumps, which are going to use up energy, and therefore the person becomes thinner. Now, if you could figure out how to do that in a safe way, you'd probably be a billionaire or a zillionaire because people would buy your product and lose weight on it. And if you can figure it out, let me know too, and I'll cash in on the profit. Hopefully. Okay. All right. So, and this is just showing you like the phosphate ions, which are the bulky anions, and the protein, which are negatively charged. So, and then the sulfates also are here, but they're not shown in this diagram. Okay. So now that we know what these resting membrane potential is, we can look at graded potentials. Remember, graded potentials are going to travel over short distances only because they're decremental, which means that they go down in amplitude in time. Right? This is the time in milliseconds on the x-axis here, and the membrane potential on the y-axis in millivolts. So we start out at negative 70 millivolts, and let's say you get a deviation in the resting membrane potential, which is on the downside. This is called a hyperpolarizing graded potential. Why is it hyperpolarizing? Because it's making the polarization more extreme, right? It's taking the negative 70 and dipping it down into maybe negative 75 millivolts. So it's making it less likely to fire up an action potential. So a graded potential can be hyperpolarizing, in this case here, right? Or it can be depolarizing, in this case here, in the green one. So in depolarizing graded potential, you have a decrease in the negativity, right? So you have an increase in the membrane potential, right? Which is the graded potential. So this is going to make it more likely to fire up an action potential, whereas this is going to make it less likely to fire up an action potential. Now, what is the quick difference? Like, just mention it quickly and then we'll go back to it later on. This is, for example, because of chloride channels opening and letting chloride in, which is negatively charged, that's going to make the cell more negative inside, right? More negative, and less likely that it will amount to an action potential. So this is a hyperpolarizing or inhibitory graded potential. And then the depolarizing is perhaps due to sodium ions moving in, right? Sodium channels opening up, sodium ions moving in, making it more positive inside the cell and therefore less negative, right? So it goes up to negative 60. Okay. So in the case of a mechanical stimulus, you press on the skin, for example, and you open up this channel and it lets in calcium or sodium and it makes it a depolarizing potential, right? Depolarizing. And then this one is binding acetylcholine, so it's ligand gated, right? Ligand stimulus here, ligand gated. It's going to bind to the receptor, going to let sodium inside the cell, make it a depolarizing graded potential. So both of these are depolarizing because they're letting in positive ions through that channel. And then this one is an exception. This is the binding of glycine. Glycine is an inhibitory neurotransmitter. Neurotransmitters are chemical substances by which the neuron communicates with other effectors or neurons. Okay. So when you bind glycine, right, it opens up this channel, which is a chloride channel. Chloride, being negatively charged, is going to come inside the cell and make it a hyperpolarizing graded potential. Okay, hyperpolarizing graded potential because we have negative ions moving in and making the cell more negative inside.
Okay? I thought that was positive that was moving in.
No, in this case, it's the chloride ion that's moving in, not the sodium or the calcium. It's the chloride ion, the yellow ion. And when the chloride ion moves in, it makes it less negative inside the cell because it's negatively charged.
Okay.
Does that make sense? So
Yeah,
these two receptors are different than this receptor. And that's how the body modulates these graded potentials, right?
So
Through
again,
these ion channels, basically, through these ion channels. So the chemistry involved here is really important. And if you have to go back to chapter 2 and study a little bit more about the ions, really important to get that concept because it's going to reoccur over and over again. And then, like I said, if you go to upper division courses or graduate school, it's going to become more involved. So really important to learn the basics here. So
Professor,
yeah.
again, when the chloride ions move in, it makes the cell inside more negative, right? Not less, or it's less.
Here?
Yeah.
Yeah, it's making the cell more negative inside.
Inside. Okay.
Because it's chloride ions. The chloride is negatively charged. Chloride is one of those ions that got formed by, for example, sodium donating an electron to the outermost shell and making it complete. So it has an extra electron, basically. That's why it's negatively charged. Okay, so really think about it, read the book, and try to really conceptualize what's going on here. It's basically just ions and ion channels that are determining the voltage of the cell, and the voltage determines whether there's going to be an action potential or nerve impulse generated or not. So the graded potentials respond to stimuli. If you have a very small stimulus, very weak stimulus, it's going to respond as such. Deflection in the membrane potential, it's going to become slightly depolarized. You have stimulus 2 that's stronger, it's going to become more depolarized. And then stimulus 3 is the strongest of the 3 here. And that shows the most depolarization, up to like negative 58 or something. Now, graded potentials, like I said before, can add up to an action potential. Now, what does that mean, add up to an action potential? When you go from negative 70 to negative 55, right around here, right? So these guys haven't reached negative 55. So you go from negative 70 to negative 55. If you reach negative 55, right, that's the threshold, they call it. That's the point at which the cell will fire up an action potential no matter what. So that's like pressing the button on the camera flash, right? Once you press the button, the flash is going to go. And what's the button? That's the threshold. Once you press it and you reach negative 55, it's going to fire up an action potential. Now, some graded potentials are large enough to cause an action potential by themselves. However, most graded potentials are not large enough to cause an action potential by themselves. And they can add up if they summate. And we'll show you how they summate here. So let me talk about action potentials, which are the nerve impulses that travel along the axon in order to communicate with another neuron or an effector. Right? So action potentials are very important to understand, and it's not that difficult once you just get the idea of the ions moving in and the ions moving out and so forth. So action potential involves a period of depolarization, which is shown here in the green curve. This is the time in milliseconds on the x-axis. This is membrane potential in millivolts again. They wrote over here negative 55 because that's the threshold, right? We start out at negative 70. You have a stimulus, right? Like a touch on the skin or a sound coming in or whatever stimulus it may be. And the stimulus is going to open up sodium channels and make the cell less negative. Once it reaches negative 55, then the voltage gated sodium channel activation gates are open. And the sodium basically rushes inside the cell. That's the depolarizing phase. And reaches positive 30. So it goes all the way from negative 70 to positive 30. That means that it travels an amplitude of 100 millivolts. That's the amplitude of an action potential, typical action potential. And then the depolarizing phase is where you have voltage-gated potassium channels opening, and then the Na channels are inactivating. Okay? So the green is the sodium channels opening, and the red is the potassium channels opening. Okay? So what happens when you open the sodium channels? Sodium ions, which are positively charged, are going to come inside the cell and make it less negative. We're going to take it all the way up to positive 30. At that level, right, at that voltage, the potassium channels will open up and let potassium out of the cell, not inside the cell, out of the cell, because the potassium is more concentrated inside than outside. So potassium is going to flow outside the cell, and it's going to make it more negative. It's going to overshoot. So this is the after hyperpolarizing phase. It's going to overshoot because the voltage-gated potassium channels are still open. And it's going to eventually come back to the resting membrane potential. Now, within this action potential, right, you have this period here, which is the absolute refractory period. It's written right here on the right. Absolute refractory period. So during the absolute refractory period, no matter how strong the stimulus, you cannot impose another action potential. Okay, no matter what, how strong the stimulus, you cannot elicit another action potential here. But during this phase here, during this period here, the relative refractory period, you can elicit another action potential if the stimulus is strong enough. Okay, so this is relative refractory period. This one over here is absolute refractory period. Okay. So I talked about this before, that action potentials can only occur if the membrane potential reaches threshold. So in the subthreshold stimulus, nothing's going to happen. No action potential is going to occur. In the threshold stimulus, you have a strong enough stimulus to reach threshold, and an action potential is going to take off because of that. And then if you have a supra threshold stimulus, which means that you're really pressing hard on the skin. Now, how does the body know that you're pressing really hard on the skin? It knows because the frequency of the action potentials is going to increase. So it's going to go sort of like that, coding wise, right? Let the brain know that there's extra pressure on the skin. Whereas this one over here may be just a light touch, right? This one here, more pressure or maybe vibration or something like that. So I'm not going to go through the whole table here, table 12.2, but please do take time during your studies to look through this table and try to make sense out of it. Don't try to memorize everything in here. It's too much tedious information, some of it. But do understand the difference between graded potentials and action potential. Okay. So let's talk about some of these. It's going to make it more clear what we're talking about in terms of graded potentials versus action potentials. So graded potentials, first of all, they originate in the dendrites in the cell body mostly. Okay. Dendrites and cell body. Whereas action potentials arise at the trigger zones and they propagate along the axons. They go along the axon. The conduction is decremental, like we talked about. So only short distances for graded potentials, long distances for action potentials. Amplitude, it can be 1 millivolt to more than 50 millivolts, which means that one single graded potential can potentially cause an action potential, but usually not. And then the amplitude for the action potential, as we saw, was 100 millivolts. Duration is longer in the graded potential because the cell has to have time to make a decision. We'll see a slide later on that shows that, but just to give you a heads up, basically information comes into the cell body of the neuron from different sources, right? And let's say you're trying to make a decision on whether to apply to this school or that school for nursing. And you list the positive points on one and list the negative points on the other, or make a table and so forth, so you see it. But the decision making is sort of like the neuron making a decision. You have these inhibitory neurons coming in and there's stimulatory neurons coming in, and they have to sort of balance each other out, and the cell integrates that information and then puts out an action potential or not, depending on the scenario. Okay. So graded potentials can be hyperpolarizing or depolarizing, whereas action potentials are always going to be depolarizing followed by repolarizing. The refractory period is not present in graded potentials because summation can occur. However, in action potentials, it is present like we saw. Summation cannot occur, okay, during the refractory period, especially the absolute refractory period. So we talked about action potentials. Now, how do those action potentials translate into nerve conduction? Okay, so continuous versus saltatory conduction. Continuous is seen in unmyelinated axons, such as free nerve endings, for example, that you see in nociceptors that pick up pain. And then saltatory conduction. Saltatory means jump from node to node. node to node. So in myelinated, you have an internode that has myelination, which is this box here, 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 and here. And in between them are nodes of Ranvier, which don't have myelination. So here, here, and here. Now, the action potential originates from the axon hillock. That's where the sodium ions are going to come in. And then, since the nodes of Ranvier have the highest concentration of sodium channels, right? The sodium channels are mostly concentrated in the nodes of Ranvier. So therefore, the conduction is going to occur from node to node, node to node. A little bit of conduction is occurring still very slowly within the axon, within the internode, but most of the conduction is occurring from node to node. Right? So it jumps from here to here to here to here. And that's what makes it so fast. So myelinated axons are going to conduct action potentials at a rate of 100 to 120 meters per second. That's running the 100-meter dash in 1 second. That's pretty fast. Whereas unmyelinated axons take about 10 to 20 meters per second, so much slower. Now, there are some factors that affect propagation speed of the action potential. That's the axon diameter, the amount of myelination, and temperature. So, axon diameter. For example, I talked about the sciatic nerve, right? I'm suffering from sciatica. The axon diameter in that sciatic nerve is larger than any other nerve in the body, right? And it travels a whole meter sometimes, depending on the length of the body. So axon diameter is gonna, the larger the axon diameter, the more the Na channels can be present on there, right? It makes sense. So as a result, since there's more sodium channels on the surface, sodium is going to rush in that much faster, and it's going to conduct much faster. That's why sciatica is so painful, because it travels so fast also. It's a large nerve and it travels very fast. The amount of myelination affects propagation speed. So we saw that on the earlier slide, how myelination is going to cause saltatory conduction, and that's going to be much faster. And then temperature-wise, I'll tell you a little scenario. When I did my rotation in medical school in surgery, I had a cardiothoracic rotation at the VA, and they were doing a cabbage procedure, which is a coronary artery bypass graft. And in order to slow down the heart or make it stop, actually, they cooled the blood considerably, like 4 degrees centigrade, cooled the blood down, and that made the heart stop beating so that the surgeon could operate on the heart. It would be very difficult to operate if the heart is beating and you're trying to sew up an artery on the heart. So lower temperatures are going to decrease propagation speed, which is why they say right after you get an injury, like a sprained ankle or something, as long as it's not broken, put some ice on it, right? Rest, ice, compression, elevation. So you put ice on it, and that slows down the propagation speed of the pain signal, the neurons related to the pain, and it relieves the pain, right? Okay. Okay, any questions from you guys so far? Anything you don't understand, want me to go over? Okay. Okay, so let's talk about signal transmission at synapses. What is a synapse? A synapse is basically a very, very tiny space between a neuron and another neuron, or between a neuron and an effector cell. Okay? So it's the junction, right? It's not really touching. There's a few angstroms, which is a very, very tiny space between the neuron and the effector, or between a neuron and another neuron. So we have electrical synapses that are like gap junctions, which are present in cardiac muscle, for instance. And we have chemical synapses that allow one-way transfer of information from a presynaptic neuron to a postsynaptic neuron, or from a neuron to an effector. So different ways by which neurons get innervated, right? Innervated means get nerve supply. So one of them is axodendritic. Don't be alarmed by the names. I'm not going to test you on these, but make sense out of the name, right? Axon, dendritic, dendrite. It goes from an axon to a dendrite. Axodendritic. Those are one kind of synapses. Axosomatic, it goes directly to the cell body. Those are another kind of synapses. Axonic goes to the axon from another axon. Right? So these are just different synapses that you can see. Now, what happens at the chemical synapse? How does the nerve communicate with an effector or with a postsynaptic neuron? So first of all, a little bit of terminology here. We have the presynaptic neuron, which is the neuron that's going to communicate with the postsynaptic neuron. So presynaptic means before the synapse, postsynaptic means after the synapse. And a synaptic cleft is this space right here. So the neuron does not touch, the presynaptic neuron does not touch the postsynaptic neuron. It sends a neurotransmitter that travels across the synaptic cleft to bind to a receptor on the postsynaptic neuron, which will act as a ion channel that we saw, ligand-gated channel. It's going to open up, let sodium in, and cause a nerve impulse inside the postsynaptic neuron. Now, how exactly does that occur? You have the nerve impulse coming in, action potential coming in from the presynaptic neuron. It reaches the synaptic end bulb, which is this widened portion here. Why is it widened? Because it has all these synaptic vesicles, right, that have neurotransmitters in them. And when the nerve impulse comes in, there are some voltage-gated calcium channels here in purple that are going to let calcium inside the synaptic end bulb, inside the neuron. And when the calcium reaches, it opens up these vesicles, it causes them to fuse with the membrane of the presynaptic neuron and release the neurotransmitter in the synaptic cleft. Okay, that's how they communicate. Now, it's not always going to be acetylcholine, it's not always going to be sodium, but that's how they communicate. So, going back to the words depolarizing and hyperpolarizing, so we can have postsynaptic potentials, right? Postsynaptic means that the membrane potential in the postsynaptic neuron, essentially. So we can have excitatory postsynaptic potentials, which are depolarizing, which means that they go up on the curve. Remember, the green goes up. Inhibitory postsynaptic potentials goes down on the curve, and makes it less likely to fire an action potential. Postsynaptic neuron can receive many signals at once, right? So it can look like this. So we can have presynaptic neuron number 1 sending an EPSP, excitatory postsynaptic potential, because it has an excitatory neurotransmitter such as acetylcholine or glutamate or aspartate. This one is an IPSP, which means that it's in red. So you have an inhibitory neurotransmitter right here, inhibitory neurotransmitter, also seen in presynaptic neuron 4. So this is the decision making that the cell has to undergo in order to decide whether to fire up an action potential and communicate with another neuron or effector or not. So all these stimuli are coming in. Imagine the Purkinje fibers, Purkinje cells with all their dendritic branches, right? 10,000 dendrites. Information coming in from all these different sources. The cell body here will integrate all these input and then send an output to the axon. Okay. Okay. At the chemical synapses, the neurotransmitters can either be excitatory or inhibitory, depending on the receptor, right? So neurotransmitter receptors have 2 structures. One of them is inotropic, one of them is metabotropic. So inotropic is where the receptor is the ion as well. So you can have acetylcholine binding to the receptor like we saw before, letting calcium or sodium inside the cell, and making an EPSP, excitatory postsynaptic potential, which means that it's making it more positive, right, inside the cell. This one here is also inotropic, which means that the channel is also the receptor. So it binds GABA, which is an inhibitory neurotransmitter. And the way GABA works is that it opens up chloride channels. We saw this before, right? Chloride ion is going to enter the cell and make it more negative. So it becomes an IPSP, inhibitory postsynaptic potential. Okay? Don't get lost in the names, you know, try to make sense out of them. This is more physiology, so it's more like making sense out of it rather than memorizing. And then the metabotropic, this one is acetylcholine receptor, it's metabotropic. That means that the receptor is separate from the ion channel. So in metabotropic, the acetylcholine is going to bind to the receptor. The receptor is bound to a G protein that's going to dissociate and open up a potassium channel here. And that's going to be an inhibitory postsynaptic potential because you're having positive ions leave the cell, making the cell more negative, hyperpolarizing. Okay. Now, neurotransmitters can be removed from the synaptic cleft by diffusion, so they just diffuse out, or enzymatic degradation, like acetylcholinesterase, that breaks down acetylcholine into choline and acetic acid, which is basically just vinegar, and uptake into the cell. So it takes it back up into the cell. For example, the choline is taken up into the cell, into the presynaptic neuron, and recycled, right? Now, we talked about the phenomenon of summation. Summation may be spatial or temporal. Okay, so this is spatial summation, which means that you have more than one neuron, more than one presynaptic neuron, innervating the postsynaptic neuron. Okay, so you have the first neuron, the second neuron, and you have many of them that are going to add up to the negative 55 threshold and cause an action potential to occur. Okay? Or you could have temporal summation, where you only have one presynaptic neuron, but it's firing at a rapid rate, right? Because the stimulus is strong enough. Remember that slide with the super threshold stimulus that causes increased frequency? So the increased frequency is the temporal, as in tempo, time, summation. And that adds up to negative 55. If it does, then it fires up an action potential, right? So that's temporal and spatial summation. Any questions on what we've talked about so far with action potentials and graded potentials? Anything you don't understand at this point? Any questions or concerns?
I have a couple of questions about the acetylcholine receptor. You said sometimes they're ionotropic and sometimes it's metabotropic.
Right. Sometimes it's ionotropic, sometimes it's metabotropic.
So are these in different tissues?
I'm sorry?
Are these in different tissues or something? Or they wouldn't have the receptor in the same
cells have different receptors on them, and they do different things. And we'll dive into that more deeply when we talk about the sympathetic and the parasympathetic, because that's where it becomes really evident. But always think of the receptor on the cell, right? It's not necessarily the neurotransmitter, but it's the receptor that determines what's going on in that scenario.
Okay, and then for ligand-gated channels especially, do they only have one binding site that will only bind one ligand, or do they have multiple?
Right, they're specific, yeah. Yeah, they're very specific, yeah.
Okay.
Very good question, yeah. Good job. Okay. So neurotransmitters are chemical messengers that are going to communicate between neurons and between a neuron and an effector. So acetylcholine is in a class by itself. Then we have the amino acids, the biogenic amines, which are the norepinephrine, epinephrine, and so forth, ATP, nitric oxide, carbon monoxide. So acetylcholine looks like this. Nitric oxide is N double bond O, and carbon monoxide is C triple bond O, which is very, very hard to break. Then we have the amino acids such as glutamate and aspartate, which are stimulatory neurotransmitters, and then we have GABA, which is and glycine, which are inhibitory neurotransmitters. The biogenic amines are the norepinephrine and the epinephrine, dopamine, and serotonin. So all of these biogenic amines are used in the treatments of different mental illnesses. Right? For example, in schizophrenia, dopamine is increased in the brain. And so they give medication to decrease the dopamine levels. With depression, sometimes the serotonin levels are decreased, and sometimes norepinephrine is decreased. So they may give selective serotonin reuptake inhibitors, which prevent the reuptake or breakdown of serotonin, so it stays around the synaptic cleft longer, and the person gets less depressed or gets well. Norepinephrine is found in Wellbutrin, which is a medication they give for depression as well. Sometimes psychiatry works in reverse. Instead of finding the disease and then giving the medication for the disease, they give the medication first. They know what the medication does, and if it works, then they say, okay, the person has this, which is kind of weird, but sometimes it works like that. So let's say the person is depressed and they give him Wellbutrin and they get well. Well, they say, well, he had a deficiency in norepinephrine because Wellbutrin is going to increase the norepinephrine levels. Okay. Also, we have the neuropeptides. Substance P is an example of that. Substance P is the chemical that's implicated in pain. So P is in pain. And then we have the enkephalins, endorphins, and dynorphins, which are natural painkillers. So when the runner gets that runner's high, that's the endorphins basically kicking in and giving the runner the runner's high and pain relief as well. A lot of them experience pain relief when they're running. Okay. Okay, let me just talk about neural circuits and then I'll call it a day. So, we have neural circuits, just like we have electrical circuits and electronic circuits and so forth. So some of the circuits are such. We have simple series, which is one neuron after another in sequence, diverging, which goes out like this, converging, which comes in like this, reverberating, which goes back, which goes in sequence and then comes back and feeds the previous neurons. And then parallel after discharge, which is parallel occurrences during activities such as breathing and walking, which demand a lot of coordination between different muscles and so forth, right? Joints and muscles and so forth. So we'll talk about these. So the simple series I told you is just one neuron after another. And this is a diverging circuit. An example of a diverging circuit is where you have an upper motor neuron in the cerebrum, right, in the brain. And that upper motor neuron is sending a command to lower motor neurons down here in the spinal cord to basically elicit a movement. Okay, so you want to kick a ball, and you've decided that you want to kick that ball. The premotor cortex has sort of orchestrated the movement, and then the upper motor neuron in the motor cortex, which is this neuron here per se, is going to find action potential, going to meet these two, and these are going to meet these two each, and it's just going to diverge like that, right? So one motor neuron can innervate thousands of lower motor neurons down here. This is a simplification, of course. Thousands of motor neurons down here from one motor neuron up here. Okay, that's how that works. A converging circuit is the opposite of diverging. So you have multiple inputs, right, and one output. Example of that would be the Purkinje cell in the cerebellum. I use that as an example again. So the cerebellum Purkinje cell is sitting right here. It's getting input from the eyes and from the vestibular system, which has to do with balance and equilibrium from the inner ear, and getting proprioceptor information from the proprioceptors, which are receptors located in the limbs, in the joints, to give us information about limbs in time and space, at any given time and space. So all this information is coming in through these 10,000 dendrites, and it's going into the cell body, making a decision and sending an output to the brain saying that, yes, this movement is possible, you know, or no, it's not possible, better not do it and break your neck. Reverberating circuit is where you have a circuit in series, and then the later neurons come back and reverberate or go back and innervate the previous neurons. So what does that occur in? That occurs in memory, short-term memory, where the cells are going back and going, oh, this was 251, 652, 1217. Okay, 651, 212, 1217. So it goes back and tells it to keep remembering it. It's sort of like repeating it to yourself, right? You see something and you want to just repeat it to yourself to remember it. Parallel after discharge circuit is where you have several circuits in parallel that have to have coordination of events, activities, so that the arms and the legs are moving sort of in synchronous with each other and not kind of out of whack and kind of like the guys dancing and walking at the same time. So this coordination requires that kind of circuit, a parallel after discharge circuit. Okay. So that was the circuits. Now we're gonna just touch upon regeneration and repair. So although the nervous system has plasticity, which means the capability to change based on experience, it has limited regeneration ability, right, in the central nervous system. In the peripheral nervous system, there is regeneration that occurs all the time. Like when a surgeon cuts tissue to open up the abdomen, let's say, and then it closes back up, sutures it, and the nerves regenerate. You get that tingling sensation, and they come back and they regenerate because their cell body is still intact and the Schwann cells are intact and they can myelinate and everything. But let's say a person gets a stroke, right? And the cells die, the neurons die. Are they going to come back? No, they're not going to come back. That's why it's a big problem, right, with stroke patients. But plasticity is the capability to change based on experience. For example, if a person is placed on a psychotropic medication for whatever reason, let's say for schizophrenia, they take their medication for years and years and years. Now, has the brain changed, do you think? The brain has definitely changed because those medications are acting on receptors and changing the receptors and therefore changing the composition of the brain, how the brain thinks. The schizophrenic patients without medication and with medication are two different people, right? Completely different people. So that's plasticity, really, as an example. The other reason there's little or no repair in the CNS is because there's a rapid formation of scar tissue by the astrocytes, right? Astrocytes are going to lay down scar tissue and they're going to isolate that infected part or that part with the stroke or whatever. And that's going to make it harder to reach in there and to correct the problem. So in the PNS, repair is possible if the cell body is intact. So this is really important here. If the cell body is intact, the Schwann cells are functional, and scar tissue does not occur too rapidly. So we have chromatolysis, which is degeneration of the Nissl substance. Remember, the Nissl substance is basically aggregations of endoplasmic reticulum, which makes a lot of protein. Okay. Let's see. So this is a normal neuron here on the top. It has the myelin sheath and the nodes of Ranvier and the axon and the Schwann cell. Now, there is going to be some disruption in the peripheral axon here, the axon. And as long as you have Schwann cells that are present and you have a cell body that's intact, you can form anterograde regeneration, which means that there's a regeneration tube made by the Schwann cells, and then the material, the proteins, are made by the Nissl substance or Nissl bodies and taken down to the site for repair. So regeneration does occur. And then just touching up on these 3 disorders, just out of the hat, so to speak. Multiple sclerosis is an autoimmune disease where the body's own immune cells, the immune system, attack myelin in the central nervous system. And they destroy the myelin and they cause sclerosis or hardening of the axons. And therefore they disrupt communication of the axons. The epilepsy is basically due to many different causes, but epilepsy is basically due to abnormal discharges from cortical neurons. And if somebody has an epileptic seizure, there's different kinds of seizures, you know, tonic, clonic, and generalized, and localized. And but if somebody's having a seizure, you want to sort of give them a comfortable space, but you don't want to intervene by putting your fingers in their mouth so they don't bite their tongue or something. Some people think they should do that, but you shouldn't do that. You should just let them have the seizure, give them a comfortable space to have the seizure, and they will recover. But that's the danger of epilepsy, is that it doesn't give a warning sign. So it can be, a person can be driving, and all of a sudden they have a seizure, and which is why some people with epilepsy can't drive. They have their driver's license taken away. Other times, if the person is having a seizure while they're walking on asphalt or concrete, that can be, of course, dangerous because they could fall and hit their head and possibly even die from that. Okay, depression. There's different spectrum of depression. You have euthymia, which is normal mood, and then you have dysthymia, which is bad mood. But sometimes people are in a bad mood, that's dysthymic, doesn't mean that they're depressed. Depression has a very exact definition in the DSM-5. And there's different forms of depression. There's the major depression, where the person is depressed all the time. And there's bipolar depression, where the person can be depressed and then have episodes of mania, where they go out of control with sexual activity and hyperspending and these great fancy ideas about what they're going to do in the world. And it can be very disruptive, and it's a very severe form of depression. The idea is that the person is so depressed that they want to act out by spending money and buying clothes and hypersexual and this and that in order to feel alive, right? Or in order to fight the depression. But it's really a depression. It's really a bad feeling. They're not having a whole lot of fun out there. But depression can be treated with different medications that we kind of touched upon. And like I said, in psychiatry, it works in reverse sometimes. So they see the person as depressed, but they don't know what neurotransmitter is involved, or neurotransmitters. Sometimes there's more than one. So they give them Lexapro, or they give them Wellbutrin, or they give them whatever, lithium, or whatever kind of other medication. And they see if it works or not. So I think I'm going to stop there and see if you guys have any questions for me. Any questions for me in regard to the lesson or anything else in the course?
Professor, I have a question.
Yes.
I think there's a medication for depression and anxiety, and it says that it helps you to produce more serotonin. So what does that mean?
Produce more serotonin?
Yes, what is that for? Like, do you feel happy with that, or how that works?
Right, so serotonin deficiency is one of the causes of depression. So the first drugs that came out that dealt with serotonin was Prozac. Came out in the 80s. And Prozac is known as a selective serotonin reuptake inhibitor, which means that it inhibits the reuptake of serotonin back into the presynaptic neuron. So it sticks around in the synaptic cleft longer. Okay?
Okay, thank you very much.
Yeah. That's serotonin, yeah. Anybody else has any questions?
I do have a question, Professor.
Yes.
Regarding the J2 laboratory, do we need to start practicing in Atlas and APR today for the comprehensive exam, and what should we start with?
Yes. Let me go over that real quick with you guys.
Yes, and thank you.
Yeah. Okay, I'm going to 3170 for instance. So I'm going to go to McGraw-Hill Connect. Take me to my Connect section. Okay. So right here you have the cadaver A&P revealed, right? APR. Go to the green square here. Hopefully you've entered the code already for the nervous system. And then you choose the module, nervous module. Go to topic. And so tomorrow we're going to start the spinal cord. So all this information here, let's see, if we go to my histology, there's some histology you can look at, like the multipolar neuron, the axon, synapse, all this. But some of them pertain to later chapters. You know, we don't get into the spatial senses until chapter 17. But the things that you're responsible for are all here, right? Section, topic. Yeah, so starting from tomorrow, or you can start today if you like, go to the spinal cord and the spinal cord here. Go to the dura mater. Finum terminalis. So these are all the different structures relative to the spinal cord. The cervical enlargement, cervical region, conus medullaris. So when I talk about chapter 13, I'm going to make reference to the Connect with you guys during the lecture. But for the comprehensive exam on the 23rd, you're basically responsible for all the material in here. But you have approximately 3 weeks to do it. Okay, so as we go through the chapters, like chapter 13 is spinal cord, 14 is the brain, 15 is autonomic. And as we go through the chapters, I'll elucidate all of these in the Connect with you guys.
Okay, and from chapter 12, do we have anything to look at? The neurons?
Yeah, there's just a little bit of histology and you can look at, like here. Multipolar neuron is shown here, for example. And the axon. There's an axon that's myelinated. There's an axon that's not myelinated. This is myelinated axon. Unmyelinated axon. This is an electron micrograph, basically. And the synapse.
Here in the book too.
The synapse is right here. Junction between different neurons. Right here. This is the presynaptic terminal. Synaptic cleft. Synaptic vesicles. So these are filled with neurotransmitter, for instance. Okay. And then neuromuscular junction. This is the neuromuscular junction. When the nerve is attaching to the muscle here. You have the axon of the motor neuron. You have the motor end plate and the skeletal muscle fiber. And then going back to the spinal cord, what you're going to study tomorrow is basically the spinal cord and the different regions of it here. But I'll go through these as I go through the lectures that pertain to the Connect. Okay?
Okay, thank you.
Yes. Okay, any other questions you guys have? It's 10:30, so time to stop the recording.